Hello friends, welcome to the World Congress on Cardiac Imaging and Clinical Cardiology. I am Dr. Pankaj Manoria. I am an intervention cardiologist working in Bhopal for the last 15 years. I am here to talk or give you insight as to why doing intracoronary imaging is very helpful in doing coronary angioplasties. Basically, imaging, either IVUS or OCT, is like a third eye of intervention cardiologist. The detailing everything what we see on IVUS or imaging cannot be compared with what we see in angiography. Because more often than not, we have seen when we do image-guided angioplasty, we get a better stent expansion, we get a better result, which in turn translates into long-term outcome. We have number of studies to prove this point that imaging does help in doing angioplasties and long-term results. The latest study was the Renovate Complex PCI study, which I discussed in my lecture. It clearly suggests that when we do image-guided angioplasties, we reduce the chance of stent thrombus by almost 30 to 50%, reduce the chance of re-intervention by 25%, and also it improves mortality by 29 to 30%. Large meta-analysis was discussed in the recent European Society of Cardiology meeting at Amsterdam, in which 12,000 patients were studied, almost 20 trials were enrolled, and this meta-analysis was discussed by Professor Greg Stone, and they suggested when we do image-guided angioplasties, the chance of stent thrombosis, target lesion failure, target vessel revascularization, and again re-MI or cardiac mortality is reduced significantly. Why this has happened? Why imaging improves outcome? Because when we do image angioplasties, we see before intervention, we see exactly what is the morphology of plaque we are dealing with. If we see a calcified plaque, we are well prepared to deal with it. What is the length of the stent to be chosen, and what are the diameters to be chosen? So pre-PCI, gives us a very exact information as to how to proceed to the angioplasty. After angioplasty, we see whether our stents are expanded or not, whether they are opposed or not, and whether they are distal dissection or some plaque prolapse or whatever is their complications or not. Everything can be precisely seen. We don't do any guesswork. So it removes all the guessworks. All precision angioplasty can be done very accurately with image-guided angioplasty. So there's no confusion as to image-guided angioplasty is very helpful, but there are certain subsets of patients in which it is a must. I can say it's a class 1 or to class 1A indication and using this in this category. There are 5 categories in which imaging is must. First is the left main intervention. Second, in calcified lesions. Third, in a case of stent thrombosis. Fourth, in a case of ISR. And fifth, we do OCT in acute coronary syndrome to see whether there's a plaque prolapse, whether there's plaque rupture or plaque erosions. So exact information how to proceed can be determined only by doing image-guided angioplasty. I think it should be done, and it is like a third eye of intervention cardiologists, and it is for those intervention cardiologists these are the glasses of modern day intervention cardiologists who do not like blind decisions during angioplasty. Thank you very much.